Onychomycosis establishes a branching fungal network that drives deep into the porous keratin of the nail bed, resisting easy eradication. The active infection presents with severe visual pathology, thickened, crumbling, discolored nail plates, while the clinical objective remains the total restoration of healthy, clear nails. Patients frequently request an immediate cosmetic fix, yet the biological reality of the infection creates significant pharmacological hurdles for the provider. Treatment requires navigating a narrow clinical corridor between localized lacquers that rarely penetrate the nail and oral medications with systemic consequences. Addressing fungal nails requires more than a simple prescription. It demands a structured approach to evidence-based guidelines to prevent patient harm. Topical treatments often fail to reach the site of infection, while oral systemics carry the potential for serious hepatic damage. To achieve a safe clinical cure, the provider must accurately identify the visual morphological subtype and match it to the corresponding prescribing algorithm. Developing a plan for systemic intervention requires a framework of clinical governance to mitigate these physiological risks. Onychomycosis presents in several distinct forms. Effective treatment begins by identifying the specific morphological subtype shown in these clinical illustrations. Distal subungual infection is the most frequent presentation, where the pathogen enters at the leading edge of the nail. In practice, this creates a yellowed, jagged edge. The nail plate thickens and becomes brittle as the fungus tracks backward toward the cuticle. Proximal subungual infections originate near the cuticle, while candidal infections often involve the surrounding tissue and destroy the underlying nail architecture. Severe, untreated cases result in total nail dystrophy, where the plates across multiple digits become opaque and significantly thickened. This visual stratification acts as a mandatory gatekeeping step, ensuring that weak local treatments are not used for aggressive systemic-level infections. Guidelines allow for immediate empirical treatment if the infection is clinically obvious. However, lab processing for nail specimens is mandatory under specific conditions. Sampling is required for children 16 and under, or after foreign travel. It's also necessary for unusual environmental exposures or immunocompromised patients, including diabetics and those with HIV. In these cohorts, confirming the exact pathogen is a prerequisite for managing the risks associated with systemic therapy. Topical treatments are indicated for a very narrow clinical window, primarily restricted to early superficial involvement. Even in these cases, patients must be emphasized that cure rates for treatments like a moral fine 5% are statistically low, typically ranging between 15 and 30%. These outcomes require strict compliance, involving weekly filing and application for 6 months on fingernails and up to a full year for toenails. If the patient is asymptomatic and untroubled by the appearance, clinical guidelines suggest that no pharmacological intervention is needed. Because of these low success rates, topicals often function more as a management tool for patient expectations than a reliable medical cure, reinforcing the need for systemic options in advanced disease. Systemic oral therapy is the gold standard when localized treatments are inappropriate or fail to clear the infection. For confirmed dermatyphites, oral terbinafine is first line. The adult dose is 250 milligrams daily, lasting 6 weeks for fingernails and up to 16 weeks for toenails. For non-dermatiphyte or candida infections, the second-line protocol uses oral itraconazole. This requires pulsed therapy, 200 milligrams twice daily for 7 days, followed by a 21-day rest period, repeating for several courses. Systemic success depends on matching the oral drug class and its specific dosing schedule to the identified fungal strain. However, the primary barrier to using these systemic medications is the silent biological stress they place on the liver. To manage this, clinical governance requires liver function tests at baseline and exactly 1 month after beginning treatment. Terbinafine presents a rare risk of idiosyncratic liver reactions, occurring in approximately 1 in every 50,000 to 120,000 cases. In contrast, itraconazole carries a higher risk of mild transient transaminitis, affecting 1 to 5% of patients. Following the 1-month LFT check is the only way to ethically manage these risks while seeking a clinical cure. A common misconception is that oral medication must continue until the nail plate is visually clear. The actual endpoint for stopping medication is the appearance of healthy proximal nail growth at the cuticle. Once this growth is established, the medication can be discontinued. Even with successful treatment, the chronic nature of the disease means recurrence rates are high. Long-term management requires strict hygiene interventions, including keeping nails trimmed short and replacing contaminated footwear. Effectively managing onychomycosis requires moving past the low success rates of topicals to execute systemic protocols and liver monitoring for a safe, measured clinical outcome.